of introducing Dr. Joe Zunt, who I've never met before, but know him very well by reputation. Dr. Zunt is MD, MPH, who works at Harborview Medical Center. He is trained in both neurology and infectious disease and has a special expertise in infections of the nervous system. In addition to being a very well-regarded clinician and somebody who many people go to for challenging CNS infection cases, he's a very active researcher internationally with work in Peru and many other sites. In reading his bio, I was very impressed that he is the co-director of three NIH-funded research training programs and has mentored literally hundreds of medical students from both US sites, but also international sites. And we're very happy to have Dr. Zunt speak about CNS TB. He has given us license to interrupt him during the talk and ask questions. So if you do have questions, please either raise your Zoom hand or put it in the chat, and we'll address them as we go. Please take it away, Dr. Zunt. Thanks very much for speaking.
Great. Thanks for the opportunity, and great to see Chris and Masa in the audience. We've gone back dozens of patient consultations in the past. So for me, yeah, once something gets in the brain as far as an infection, I'm very interested in. TB in particular, I think has been a conundrum for years and continues to be. My grandpa had TB and lived in a sanitarium. I always forget if it's sanatorium or sanitarium, whatever they called it back then. But he lived there for 7 years when my father was in grade school. So kind of missed those years. But boy, it continues to be devastating, as all of you have seen the WHO numbers again. I mean, it's kind of like syphilis. You just can't get rid of it. But certainly appreciate everyone's trying. And hopefully today I'll be able to give you my insights into CNS TB, which is, I guess if I can say one thing, it's nearly always treatable. I have seen so many patients come in looking like they're on death's doorstep, and we treat them with all of you. Making sure they're adherent to their therapy, and they can have miraculous recovery. So that's one thing I always teach our residents too, that just because it looks like the worst meningitis you ever seen, treat, because with treatment, people do get better. So I'm going to try to move this little thing out of the way here. Here we go. All right, so TB in the nervous system. Now, if I can get, there we go. So don't have any interesting disclosures to make. And these are the objectives. So again, going to talk about CNS tuberculosis and really the continued challenge in diagnosis. And then talk about the different manifestations of CNS TB. And then I'm glad that you're not all neuroradiologists, so I'll try to give you some of my pointers in looking over brain imaging. So terminology, I'm sure all of you already know these. I don't have many acronyms, fortunately. So this is one of those. Let me see if I'll put that laser arrow pen. There we go. I guess you're able to see my little pen now. Yeah, I guess just the continued resistance of TB to all of our efforts to control it and eradicate it. This is a poster from very distant past. Anyways, what I'll talk about, I've already kind of outlined. I'm skipping a lot of the epidemiology because a lot of you already know where TB is and where it emerges from. So I'll talk more about imaging, how to diagnose CNS tuberculosis and treat it. And then if there's time, I'll get into HIV co-infection. And I agreed that I'll take a pause before I get to that point and answer questions. But as I go along, feel free to type in a question or raise your hand, and I will interrupt what I'm saying. So I had a lot of epidemiologic slides regarding TB in the world, and having worked in TB in Peru, But they've got the extra problems of MDR, multiple drug resistant, and extremely drug resistant TB, which, as all of you know, just poses yet another layer of difficulty. But as far as the people that we see here, here meaning Harborview, where I do all of my clinical work, these are factors that I'm always taking into consideration when I have someone coming in through the emergency room, through the clinic, often through referrals with some type of either meningitis or some kind of space occupying lesion. And what goes through my mind is, well, what have they been potentially exposed to? And TB, just because I'm at Harborview and it's such a diverse population, is always on the top of my list as a potential diagnosis, especially in those people that come in with kind of more chronic presentations that tend to come in through the clinic. So I won't go over these in detail, as I suspect you know all of these risks as well, given that all of you are out working with people at risk or with TB. So I'll jump right into CNS TB. And I'm not going to talk about when it affects the spine, but obviously when it affects the spine, then it's just a short hop, skip, and a jump into the nervous system. So not uncommon at all if someone has Pott's disease involving the spine, that it can then traverse into the meninges and give you a meningitis. Or if it's in the lower spine, it may affect some of the nerve roots there and give you kind of radicular type pains, say radiating pains or weakness. But I will focus more on what's in the central nervous system. So meningitis tends to be one that we see the most. I think this is an area where pediatrics may have an easier time diagnosing TB meningitis, just because kids with meningitis, TB meningitis tends to occur most often in kids, and those kids that have it, the majority also have active pulmonary TB. So I guess my other little, for want of a better word, pearl that I'll toss out is that when I'm considering TB, I am always looking for other places that it lives. Especially the lungs, obviously. So if there's a nice lymph node that is accessible by some of our colleagues in pulmonology, that's fantastic, because getting the neurosurgeons to go in to get us some tissue is problematic, to say the least. And I'm kind of jumping ahead to the kind of the money, but it's all in the diagnosis, because so many times we're treating presumptive diagnosis when we have a chance to treat confirmed TB. That's just so much better than committing someone to a duration of anti-TB medication that certainly is going to give them some side effects, most likely. So back to what I was saying. So when I have someone coming in with possible CNS tuberculosis, I always look elsewhere. And by looking elsewhere, I recommend to our teams that we get a CAT scan of the entire body. So pulmonology, or sorry, lungs, abdomen, pelvis, and looking for lymphadenopathy, looking for other types of pulmonary disease, where potentially we can have our colleagues in, say, interventional radiology or pulmonary be able to get a biopsy. But anyways, back to this. So meningitis, and we often will see that come along with some cranial nerve abnormalities. So facial, auditory, ocular motor, kind of diplopia, hearing loss, facial droop. Those are cranial nerve problems that we'll often see with meningitis. Tuberculoma. This is a picture of a tuberculoma here. You can see it's basically I guess, a glorified granuloma, or I should say abscess, where it kind of grows large, and lots more bacilli in there, what can make it easier to diagnose if you can get a piece of it. The abscess is basically a liquefied tuberculoma. And then finally, the vasculitis, which I won't touch on much, but I do want to bring up because it's one of those complications, mainly of meningitis. I'll show you some pictures later of TB meningitis, but often it will include the basilar meninges, so all around the brainstem. And as you may remember, all the major blood vessels come up two anterior and two posteriorly. And once you have all that inflammation from the meninges in that area, it tends to affect those blood vessels and can give you inflammation and then can give you strokes that result from that. So these are some different imaging modalities. So we have CAT scan, MRI, another CAT scan. But this is just to give you a brief glimpse. I'll show you some other patients who have had different forms of TB, CNS TB. But here is that brainstem involvement. So it looks like a star, kind of a star shape, at least on these axial cuts through the brain. And then here we have an abscess with some kind of attached daughter lesions as well with enhancement. And then finally have some smaller granulomas on my right here. So I'm going to go through a few patients that I've seen over the years, just to kind of talk about different aspects, not only of imaging, but also just how I think about the approach to both the diagnosis and the management. So this is a 17-year-old, and he had 2 weeks of fevers, chills, headache, and vomiting. Went to a emergency room. They said, oh, probably a viral syndrome, and sent him home. But then a week later, he became febrile, shaking chills. Mom couldn't understand his speech and called 911, and they brought him into Harborview. And obviously, there's not going to be a question of what does this patient have? TB. So TB. So here's what we call a coronal shot. So kind of that crown, so slicing through the brain. So axial is this way, coronal, and then sagittal would be from the side. But these are all coronal. And what you can see here is all of this white linear abnormality. This is all inflamed meningitis. So this is one of the worst cases of meningitis I've ever seen. So I didn't give you, this had been kind of an unknown presentation at one point to our residents, and I didn't give the history that he's from the Philippines and traveled back and forth frequently. So as you all know, Philippines has higher rates of tuberculosis than we have. But anybody want to also point out, other than the meningeal enhancement, anything that catches your eye? Feel free to. I don't think I can see the chat, so you can shout out if there's something that is concerning here.
I tried hydrocephalus.
There you go. Yep. Hydrocephalus. Yeah. Yeah. I have mentioned already that I tell our residents that you treat TB, CNS TB, and most often people get better. But this is one of those problems that emerge, especially with TB meningitis, hydrocephalus, that is really emergent. If you don't drain that excessive pressure, then what's going to happen? As my neurology teachers used to train me 30 some years ago, the skull can only hold so many things: brain, blood, and spinal fluid. And you get too much of any of those, and something is going to come out of the skull, and that's never good. So you can imagine that if you have hydrocephalus, that's basically just creating increased pressure and downward herniation and death. So really need to get someone in there, mainly your neurosurgery colleagues. This is a case where treating with something like steroids or acetazolamide, really to decrease the pressure, wouldn't be enough. You really need to get in there, have your surgeons put in some type of temporary drain, which is what they typically do. They don't want to put in, say, a ventriculoperitoneal shunt at this point because obviously probably going to be contaminated because the infection is still brewing. So they'll often put in an external ventricular drain while you're getting them on therapy. But I just want to bring up the hydrocephalus. And this is also something that I think is interesting. If you look at bacterial meningitis, people always talk about increased pressure as well. But if you look at the studies that have really looked well at the back of the eye for swelling or papilledema, With bacterial meningitis, it's present in less than 1% of people. In TB meningitis, it's up to about a third of people. So really get some increased intracranial pressure. So you want to be aware of that. And this may be someone too that you might not want to get a CSF sample because what happens? Well, if your increased pressure is too high in the brain, you relieve that pressure down below and you get a herniation, which of course nobody wants. So here are some axial images, and you can see the really marked ventriculomegaly here in the lateral ventricles throughout and the third and fourth ventricles. One thing I wanted to point out here too, for those who don't read many MRIs, it can be tricky sometimes to know, has there been gadolinium? So the contrast enhancement, has it been given or not? One tricky way or easy way to do it is just look at the nasal mucosa. So if the nasal mucosa is white, then gadolinium is present. So just nice leakage of the blood vessels there since it's so vascular. So that's one way to be certain that there has been contrast given. And as far as the clinical progression, I really won't go into this much in detail, other than to say this is something that often is used in, say, clinical trials to grade where people are at the onset and the end of treatment. And obviously, you don't want to get to the paralytic phase where you're really quite stuporous and potentially comatose. And then this is what I had alluded to before. So the papilledema, and this is from a long time ago, from the 1970s, a really nice study of TB meningitis. And oops, let me go back there. And you can see that the majority of people had meningeal signs, so kind of a stiff neck, maybe radiating pain when they move their neck, headaches, cranial nerve palsies, as I mentioned, and then papilledema. So as far as, well, how does this get to the brain? So the Hopkins group, the rich focus was initially postulated many years ago. And the theory was that it was kind of a seeding of the brain that was close to the cortex. And then when those little infected areas rupture into the subarachnoid space, that's when you get meningitis. And that's certainly possible and probably one of the routes. The other one that I think makes a lot of sense too is just hematogenous spread of bacilli. There was a interesting and kind of a troubling history of someone who was trying to commit suicide and injected himself with TB into the bloodstream and then died of TB meningitis 2 months later. So I guess that's one way to show that it can be spread hematogenously. I think another area that is really, to me, quite alluring and unanswered is this whole glymphatic system that has been recently uncovered in the brain. So little did we realize that there's a whole separate lymph node system that really hadn't been visualized well, that they're now referring to as the glymphatics. So obviously, lymph nodes get swollen and infected with TB. So could it be that the glymphatics is another passageway to the brain? Who knows? But going via the bloodstream is certainly the quickest route to most parts of the body. So as far as other things to be aware of, I think one of the issues I already mentioned was the hydrocephalus that develops. And for those of you who have seen a lot of TB, you realize that this arachnoiditis and the thickness of the meninges is quite impressive. And it really gets just so matted that it kind of covers all of those areas and then kind of blocks the drainage of CSF. So not surprising that so many people will get hydrocephalus. Vasculitis, I mentioned. The other point I wanted to bring up here too is as far as not only the meninges being swollen, but that protein level getting high too. So you can get not only the blockage of drainage from physical structures, the meninges, but you can also get the protein that is just so thick that it doesn't flow well. You can develop CNS or CSF blockage within the spinal canal as well. I think one interesting test that has emerged in many countries where we don't have advanced diagnostics, and which we were still doing in Peru a decade ago, and they probably still are doing too for just to show what happens, but is the web that can form in the spinal fluid. If you just set it out in a little aliquot of CSF on your windowsill, and you wait 6 to 24 hours, and then because of the high protein, you'll start seeing it form these little spider webs growing. So, I mean, it's basically just an indication of really elevated protein, but I guess it's one of those things that neurologists get excited about. So one other area I wanted to emphasize, and this is more for when I'm thinking about patients coming in with chronic meningitis. And chronic meningitis, if you wanted to be a purist, you would say, well, you have to have abnormal CSF 0.1 and then 30 days later. If you've gone a month with abnormal CSF, you have chronic meningitis. But I mean, how many patients have I seen that have come in and I said, I've got these symptoms that have been going on for months, but I only have CSF from a week ago. Do they have chronic meningitis? Perhaps. So I would say whenever my concern is up for chronic meningitis, then TB is always on that list. Fungus is always on that list. Cancer is always on that list. And then more recently is that the paraneoplastic kind of goes along with neoplasm as well, and some of these autoimmune disorders as well. But the reason I show this slide is really to give you an idea of one factor which I find is incredibly useful in differentiating between multiple different varieties and trying to rule out, in particular, bacterial meningitis, which really is rarely. This rule is not true that if your CSF white cell count is above 1,000, that it's bacterial. If it's in this high range, then it's pretty much always going to be a bacteria. And then if it isn't, then it's everything else. So what does that help you with? Well, it helps you eliminate at least bacteria. So I want you to keep that in mind. And then I have let's see. Yeah, so this is just on TB alone. So your eyes may be drawn to the lower part of the slide and say, wow, you have cultures positive in 83% of your patients. No. This is after, say, 3 or 4 aliquots, and it's a question that always comes up with our residents too. So kind of the rule of thumb is if you're looking for the etiology of chronic meningitis, in particular, in this case, CNS TB or meningitis due to TB, I like to send 3 aliquots, and I like to send 3 full tubes. So those of you who do LPs, you have this kit, and it usually has a little plastic. Whoops! I'll not try not to do that one again. Anyways, you have the ability to collect about 8 cc's, and what I like to do, and being a paucibacillary condition. Or even if it is another cause of chronic meningitis due to fungus or neoplasm, I mean, the more cells you can get, the higher likelihood you're going to make the diagnosis. So I like to get 1 full tube, bring that down to the lab and say, spin this.